My goal for you is that you pass step 1, and I want you to pass step 2 as well. If you'd like to support the free work we're doing here, consider liking and subscribing. Your time is very valuable, so let's dive right in. A 42-year-old woman with a history of HIV infection is currently receiving antiretroviral therapy, including stavudine. And just as a reminder, stavudine is an NRTI, which stands for a nucleoside reverse transcriptase inhibitor, that mimics and it terminates the viral DNA chain. So it stops DNA synthesis. All right, so it's a medication that you can take, and you have to know it's a thymidine analog, NRTI. So think you are inhibiting reverse transcriptase after phosphorylation. All right, her latest lab results show an increase in her HIV viral load over the last 2 clinic visits, despite good compliance with the medication regimen. All right, so there you can see the patient. There's a rough sketch in the body. There's a helpful little diagram. There's the bottom line. Genetic testing of the HIV strain reveals a mutation associated with resistance to stavudine. Which of the following molecular targets is most likely implicated in the development of the resistance? All right, so we already talked about how this is going to inhibit the reverse transcriptase. And we know that because it's an NRTI. So the high yield fact you need to know for step 1 to answer this question correctly is that mutations in the reverse transcriptase gene are the most common mechanism of resistance to NRTIs. Basically, we have a drug that inhibits this, and so if we change this, then we get resistance. And the way to think about drug resistance on step 1 is anytime you have a high viral load despite compliance, that is to say they're taking the medication, then you should think of drug resistance. And in order to answer the questions about drug resistance, you need to know the mechanism of action. And the mechanism of action is all over this exam. You have to know the MOA of every single drug. But it's easier than you think because you can cluster the drugs together, and usually they have common nomenclature. So we have a reverse transcriptase mutation, and that disrupts the binding of the drug to the enzyme, right? You can no longer bind there. M18V, K65R, or thymidine analog mutations, commonly referred to as TAMs, reduce the efficacy of stavudine. All right, so make this super crystal clear before we go over the answer together. You should first recognize this medication is an NRTI. You should know this is phosphorylated in host cells to activate the triphosphate form. And now these will incorporate into viral DNA during the process of reverse transcription. And that causes what we refer to as a chain termination. I like to think of that one scene from Emperor's New Groove. He's like, you threw off my groove. NRTIs, they throw off the groove, right? They're activated triphosphate. They just throw off the groove of the reverse transcriptase. And that is the reason why our answer is HIV reverse transcriptase. What happens is you get a mutation that alters the enzyme structure, and that reduces this binding process. That is how we develop resistance. This allows increased viral replication, even though the patient is compliant. So we got a patient right here. Look at her. She's so compliant. And the bottom line is stavudine resistance in HIV is primarily due to mutations in HIV reverse transcriptase. You know this because you recognize that this is an NRTI. You know it's a thymidine analog that targets HIV reverse transcriptase. You distinguished it from other HIV drugs, and you probably knew that because you watched our video on NRTIs. And because of that, you selected reverse transcriptase gene. It's important to know why the other answers are wrong. A, viral entry co-receptor. A good example of this is Maraviroc that targets the CCR5. And this is irrelevant to NRTIs like stavudine. What about neuraminidase? That is a flu drug. Oseltamivir is the drug. That step 1 will question you on there. HIV protease. The answer is not C because these guys end in navir. And if you watched my video, you would know that the proteases work and they make it so you can navir transcribe. That's the mechanism of action of protease inhibitors. And stavudine, being an NRTI, is not affected by protease mutations. D is winner, winner, chicken dinner. E, DNA-dependent DNA polymerase. Well, that would be the herpes viruses, like acyclovir. The HIV uses RNA-dependent reverse transcriptase. So those are the reasons why the trap answers are wrong and why D is correct. I was working with a student the other day and they had a question about DNA-dependent DNA polymerase. It's kind of confusing, but in the name DNA-dependent DNA polymerase, we know that it's an enzyme that's used by DNA viruses. So you have to know the DNA viruses, and again, I have a video on that, but for DNA virus, let's think of like herpes or CMV. And DNA-dependent DNA polymerase is used to copy their DNA to make more DNA. Drugs like acyclovir and ganciclovir, their job is to stop that enzyme, which then will stop the virus. Okay, so why is that not the answer? Well, this does not apply to HIV. What? Yes, it does not apply to HIV. And why not? Well, HIV is not a DNA virus. It starts as RNA. So let's zoom in here. HIV uses a different enzyme. It's not DNA-dependent DNA polymerase. You know this answer. They use reverse transcriptase, and that turns the RNA into DNA. And so drugs like acyclovir don't work on HIV because they target the wrong enzyme. Cool beans? That wasn't so bad. Again, if you like this content, please like and subscribe. Question 2, you're doing great. Here we have a 32-year-old woman, you can see her right here, very smiley, is undergoing an experimental trial involving the administration of a beta-adrenergic agonist, boy, that's a mouthful, to study its effects on different organ systems. The medication is delivered intravenously, and over several hours, various psychological effects are recorded. Which of the following effects is most likely attributable to the activation of beta-2 adrenergic receptor by this drug? Good question. I think so too. Here are the potential answers, but I want to give us the lay of the land. What's all this talk about the beta agonists? Well, beta-adrenergic receptors are part of the sympathetic, or the fight or flight system, and there are two major types that you need to know for step one. It's the beta-1s and the beta-2s. This question's asking about the beta-2s, but it's important to also know the beta-1s really quickly. Promise this won't take a lot of time. This is high yield for step one. For these beta receptors, you need to know two things. One, where? Where is it located? And two, what does it do? So answer along at home with your popcorn. Hopefully you guys are treating yourselves. Beta-1 acts on the heart, and it also acts on the kidneys. What does it do? It increases the renin. I like to remember you have one heart, and it kind of seems like you have two lobes of your lung. Beta-2, where do you think that acts? It also acts on the GI and the uterus. Okay? Those are some examples there. And so what does this do? Smooth muscle relaxation. And so now we're kind of getting the lay of the land here, and we understand that beta-2 acts on the lungs, and this is a question involving the beta-2s, and so the answer is going to be something involving the airway, and bronchodilation is indeed correct. So here's an explanation that you can pause and read, but basically beta-2 is your smooth muscle relaxer. What it does on the lungs is it does bronchodilation. That's a fancy word for saying we're opening the airways. We can breathe. The vasculature is going to vasodilate in the skeletal muscle, and we mentioned the uterus is involved too. It's going to relax the uterus, right? It stops preterm labor is what that's used for. In the GI tract, it's going to slow motility. Smooth muscle is just going to be relaxing. That's its job. Beta-2, nice and relaxing. The pancreas and the liver, well, there we have to go into a little bit more detail, but not too much because, again, we're super high yield on this channel. We like to go into just the right amount of depth. Beta-2's effect on the pancreas and liver would be increased insulin, increased glucagon, and increased glycogen breakdown. It can also act on the eye, and that's interesting because that's actually going to decrease the aqueous humor production. All right, so that's what the beta-2 does. And you probably heard a lot of these guys, like albuterol. Heard of that one? That's used in rescue inhalers for asthma because of that bronchodilation. So beta-2 agonists, really think of that an inhaler as your first thought when you're taking this exam. Also like salmeterol, terbutaline. Those are beta-2 drugs. Terbutaline is used to stop premature labor. Okay, so the big point here for beta-2 is that we are doing smooth muscle relaxation everywhere except for one place. What is that one place we're not doing? The heart. Why? Because the heart you only have one of, and it's a beta-1. The lungs you have two of, and so it's beta-2. That's the way that you should try to remember this, okay? And so this question's like, okay, which one are we activating? And the answer is the beta-2 effect. Remember the lungs, remember asthma. So beta-2 relaxes smooth muscles. The lungs, bronchodilation. The GI, there's less motility. The uterus stops contractions. The blood vessels have vasodilation. It tells the muscles to chill out. And then the only thing you should really know that's just kind of hard about this is what we mentioned with the pancreas. Because beta-2 also acts on the cells that are not muscle, right? Like the pancreatic islet cells, like insulin, glucagon, the hepatocytes with the glycogen storage. And their beta-2 does not relax. Instead, it stimulates the secretion and metabolism via the CAMP pathway. Okay, so you might be thinking, Blake, you just said that all this stuff is nice and relaxing in beta-2, and you're saying it's nice and relaxing, but then the pancreas is doing this fight or flight stuff. Yeah, beta-2 does not relax. It stimulates the secretion and the metabolism through the GS protein pathway. All right, so what's the deal? Smooth muscle relaxation. Pancreas, increased insulin and glucagon. All right, so the big old TLDR, beta-2 relaxes smooth muscle. Beta-2 also releases the sugar and the hormones to fuel the body. And that can seem like they're at odds with each other, but it's actually perfectly coordinated. Let's imagine you're being chased by a bear. Your body has to run fast, right? Muscles need glucose. You have to breathe better, right? So the lungs are going to open. You have to think sharp, right? So the brain needs glucose as well. You have to delay the digestion. You don't need to digest your cornflakes right now. You need to run away from the bear. And so beta-2 does all of that. It's like, thank goodness for that beta-2 pathway. Lungs, bronchodilation, more oxygen, nice. The skeletal muscles, right? It sends more blood and sugar to the muscles so they can do the thing. They can run away from the bear. You pause the digestion, right? The GI, the bladder stuff, the uterus. You pause that. If you're having a baby, put that on hold. Got to run away from the bear so we can have a successful baby. Anyways, the liver releases glucose to power the muscles. And then the pancreas mobilizes and uses the glucose more efficiently. All right. So that's how we make sense of this in a fight or flight scenario. Even though I said it was like a relaxing thing. Yeah, smooth muscles, but sometimes we have to use the glucose too. So kind of different tools to be able to escape the bear. Cool beans? Hopefully that was helpful. Hopefully that was very, very clear. The bottom line is beta-2 adrenergic receptor activation primarily causes bronchodilation. All right, here's our nice looking 28-year-old man presenting to the clinic with a 3-day history of sore throat, fever, and swollen lymph nodes. Yikes, look at that swollen lymph node. Check out that diagram as well. He has no significant medical history and takes no medications. On examination, his temperature is 101.3, pulse 90, blood pressure 110/70. Physical examination reveals erythematous, pharynx, and bilateral cervical lymphadenopathy. Lab tests show leukocyte count of 14,000. A peripheral blood smear is obtained, which of the following leukocyte patterns is most likely to be seen in this patient. All right, so I like to start with the buzzwords because this test, they give you the answers in the question, right? So we got a dude who has sore throat, he's got a fever, and the only thing that stops it is more cowbell. If you know, you know. Wink. He's got some swollen lymph nodes. And so these things should make you think of a diagnosis that is Epstein-Barr virus or strep, right? So at this point, our differential diagnosis is Epstein-Barr, strep, and he's 28, right? So that's the peak age for infectious mononucleosis. And then we have a peripheral smear, and there we should look for atypical, what? Atypical lymphocytes, not neutrophils. Everybody loves to choose neutrophils, and we'll talk about that in a second. But we also see bilateral cervical lymphadenopathy, and that is classic for EBV. All right, so they love to trick you to think of neutrophilia, neutrophils, because they want you to think that it's a bacteria, but it's a viral illness, right? So pick lymphocytosis. So let's learn just a little bit about Epstein-Barr virus, shall we? The most important things for step 1. Here, I cut the fluff. Here's exactly what you need to know. Nothing more, nothing less. Epstein-Barr virus is transmitted via saliva. That's why they call it the kissing disease. Which cells does it infect? You should know this. And if you don't, that's okay. You'll know it in 5 seconds. The B cells. Via the CD21 receptors. You got to be 21 to enter this bar, right? And that leads to reactive cytotoxic CD8 T cell proliferation. And that's what causes our atypical lymphocytes. It's those infected B cells, those CD21 receptors, activating these CD8 positive T cells, which causes the atypical lymphocytosis. And the common symptoms, we already discussed those. What are they? Fever, sore throat, generalized fatigue, and posterior cervical lymphadenopathy. And that's why in our beautiful photo right here, you can see posterior cervical lymphadenopathy. You can also see some splenomegaly as well. So Epstein-Barr infects the B cells, and you get viral replication on the inside of the B cells. Check out this B. Oh my gosh, what's going on in there? Did you see this? There's a viral guy right there inside of the B cell. What are you doing, viral guy? He's replicating. And so the body responds with a massive CD8 positive T cell response. And the CD8 is looking for this guy. They're going to find him. They're going to kill him with their particular set of skills. And so these activated T cells appear as atypical, right? It's not typical to have a bunch of CD8s wandering around your neighborhood being all weird, trying to chase after my little viral guy inside of my B cell. Not fun. However, the total white blood cell count is going to rise, but it's due to the lymphocytosis, not the neutrophils. Okay, so don't pick neutrophils. Por favor, whenever you're picking Epstein-Barr virus, you got to pick the lymph. All right, so there's the explanation, kind of basically what we said here. The trap answers why they're wrong. Basophilia would be myelogenous leukemia. Eosinophilia would be allergies. Monocytosis would be for TB. And the interesting thing is 90% of adults worldwide are infected with Epstein-Barr virus by age 40. Everybody's just out there kissing each other. Cool beans? Bottom line, lymphocytosis is the most likely leukocyte pattern in a young adult with viral pharyngitis. That wasn't so bad. Again, if this is helpful, like and subscribe. It's free, it's easy, and it definitely supports the work we're doing here. Moving on to question 4. Here we have a freaky man with a hand growing out of his arm. There we go, much better. Had to regenerate that one. In 3 weeks after undergoing open repair of his forearm laceration, he's got that numbness and tingling. Upon examination, there is diminished sensation of the distribution of the median nerve. Okay, we got our buzzword. So the first thing to note, if you're highlighting this, I would say there's numbness, and there's numbness after some sort of an injury or a surgery. And so there's numbness in the peripheries, so we're thinking a peripheral nerve injury. And here they literally tell you that it's the median nerve. Okay, so that's the important stuff that we got so far. We have diminished sensation, and diminished sensation should actually make us think of axonal disruption. If it's just diminished sensation, it's probably not a complete transection, right? And a transection is if you completely cut across the nerve. The surgeon says the sensation will slowly improve. Wow, what does that mean? Regeneration, okay? That's what they're trying to get at, regeneration. Which of the following is the primary factor determining the rate of recovery? And now, here's the real kicker. The nerve needs to rebuild the axon, right? We have axonal disruption. We have to rebuild this. We know it's regeneration because the surgeon says it's going to grow back, and the surgeons are always right. Just kidding. They're not always right. So the nerve needs to rebuild the axon, and that means sending the components from the cell body to the distal axon end. So let me show you what I mean. Here's the cell body, there's the axon end. That is anterograde axonal transport. It's going the way you think. It's A-OK, so it's anterograde starting with an A. All right, they told you that it's the median nerve, and that was awfully nice of them, right? Well, median nerve injuries can have some motor associations. That would be like the thenar muscles, right? The thumb opposition, that kind of stuff. They can also have a sensory component. That'd be like the lateral palm, the first 3 fingers. And the peripheral nerve regeneration, for that, you need intact Schwann cells. And so our answer is slow anterograde axonal transport. You need those intact Schwann cells in the basal lamina, and axonal regrowth follows the Wallerian degeneration that has occurred in this patient. And it's kind of slow, right? So the anterograde transport is the rate limiting step of this recovery. Okay, so the breakdown of this question is simply we had a nerve injury. Ouch, no fun. Our nerve is hit. Our Schwann cells and our macrophages clear the debris, and then your cell body begins rebuilding the axon via slow anterograde transport. And what happens there is you have structural proteins, right? Like tubulin, actin, and that gets moved down the axon very slowly. And so the nerve regrows along that preserved Schwann cell tube, and it happens pretty slow. It's like 1 to 3 millimeters every day. All right, so that's the rate limiting, but that's why the surgeon said that it's going to be okay because of that anterograde axonal transport. You're moving the cytoskeletal components. It's the rate limiting step for peripheral nerve regeneration. Fast transport would not be enough for this regrowth, and so you have to take the slow path. All right, so there's our brief explanation. Here's some trap answers why they're wrong. Schwann cell mitosis has a supportive role, but that regrowth there does not dictate the speed. It's that axonal transport. Fast retrograde, that would be signal to the cell body, used for transporting signal molecules, not for the rebuilding. Plasma membrane receptor turnover, that would be a signal thing. And myelin macrophage clearance, Wallerian degeneration is necessary early on, but it's not rate limiting. All right, so the bottom line is the rate of sensory recovery after nerve injury is primarily determined by slow anterograde axonal transport. All right, last question, and we'll take a quick break. Here we have a super jacked 22-year-old dude presenting to the emergency department with a 4-day history of fever, joint pain, and new skin rash. Recently started sulfonamide antibiotic for acne. Temperature is 100.8. Pulse is 88. Respiratory rate is 14 per minute. Blood pressure is 120/78. Physical examination reveals a diffuse macular-papular rash on his trunk and extremities. Lab results show serum creatinine of 2, which is elevated from the baseline of 1. Urine analysis shows the following. What do we got? We got blood, protein trace, white blood cells, and eosinophils at 20%. What is the diagnosis? All right, so we should know that this guy's got some kidney problems. The key features to watch out for in this case are the increased creatinine, that's the acute renal failure, the urine analysis, which shows white blood cells, but also it shows eosinophils. There are no casts like you'd expect in a glomerular disease. There is some sort of a recent drug exposure, so make sure you mark that. So there's a fever, there's rash, there's arthralgias. That's just a fancy word for saying pain in the joint. And this occurs 3 to 5 days to 2 weeks after starting. So the medication probably caused it, right? And it's causing problems in his kidney. We know that because of the creatinine. And so this should make us think of a classic case for acute interstitial nephritis. You have recent sulfonamide exposure, fever, rash, arthralgia, elevated creatinine, white blood cells, and eosinophils. All of those things point us to D as our answer. All right, here's our explanation. Why is it not a drug-induced vasculitis? Well, there you would see purpura, hematuria, and maybe some systemic symptoms. But here we do not have hematuria with the red blood cell cast or the purpura. And eosinophiluria is not going to be typical here. How about the nephrotic syndrome? Well, nephrotic syndromes, you would have massive proteinuria. And by massive, we mean like greater than 3.5 grams per day. I'd also see edema and hyperlipidemia, but they have trace protein, no edema, inflammation that's not nephrotic. Membranous nephropathy is spike and dome. That would also have heavy proteinuria because that's a nephrotic syndrome. Renal artery stenosis would have refractory hypertension. His was normal. You'd also see like an abdominal bruit there, and you don't see that in this particular patient. So this is acute interstitial nephritis. The pathophys is you take a drug. The drug acts as hapten triggering immune reaction, right? So you get those haptens acting up. This leads to the infiltration of the interstitial kidney tissues by a couple of things, the lymphocytes, the macrophages, and the eosinophils, right? And that causes tubular interstitial inflammation. So you have impaired tubular function and acute kidney injury, and eosinophiluria is going to be the diagnostic clue there. So the creatinine tells us that we got renal problems. Urine analysis shows that we have eosinophils. And there's no CAS, so it's not glomerular disease. And there's a recent drug exposure. This is all pointing us toward acute interstitial nephritis. Thank you so much for getting to the end of this video. Please like and subscribe if you found this helpful. I made this channel because I want you to succeed. Whether you're a medical student, frantically studying, and this is your last day before you take step 1, or you're just binge watching YouTube and you came across this channel, I'd hope that you'd like and subscribe and learn more science facts, more medical facts every single day. Take care and have a great rest of your day.